Hi everyone, thank you so much for having me here today. My name is Vanessa Cubas. I'm one of the surgical registrars at Worcester Acute Royal Hospitals. I am here to talk about a project I was involved in looking at improving the provision and documentation of driving advice on discharge following elective day case inguinal hernia repair surgery. This all came about after recognizing one of the most common questions I would get following an inguinal hernia repair operation would be, when can I drive, doctor? Obviously, this question depends on individual needs and the type of operation the patient had. But what guidelines exist for inguinal hernia repair surgery? Well, the DVLA is clear that proper instructions and advice about how driving may affect safety need to be given, and that the DVLA may need to be informed of relevant conditions. What is the Royal College of Surgeons stance? Surgeons traditionally advise patients recovering from groin hernia repairs not to drive for at least a month. This was largely based on the concern that postoperative pain could prolong reaction times, and to a lesser degree, that there is a risk of early recurrence as a result of the inertial forces that occur during a sudden impact or stop. Following many prospective and randomized controlled trials, the Royal College of Surgeons has advised that you should refrain from driving for 1 week. The patient should be free from the distracting effect of pain or sedative effects of pain relief. You also need to be free from any physical restrictions, i.e., be comfortable in the driving position and be able to safely control your car, including performing an emergency stop. The insurance company should be informed of the operation, as they may have additional T's and C's, and you may invalidate your insurance cover. Lastly, you do not need to inform the DVLA. And what does the GMC have to say? If it's not written down, it did not happen. Our main aims were to ensure patient safety following an elective inguinal hernia repair and the safety of others on the road. So we wanted to look at what the surgical department knew, what we did about it, and how well it was documented. This was a retrospective study from the 1st of August to the 31st of October 2019, and then again from the 1st to the 29th of February 2020, following intervention. Data collected including documentation of driving advice, documented in clinic letters, operation notes, and discharge summaries. Additionally, we did a questionnaire aimed at the surgical department inquiring about knowledge of the Royal College guidelines. Our surgical department includes 35 members of staff, 17 consultants, 12 registrars, and 6 SHOs. We did not include FY1s as they are rarely involved in day case surgery or clinics, and it is the responsibility of the operating surgeon to do the discharge summary to facilitate flow in the day case department. So all of the 35 staff members' questions are routinely involved in elective hernia repairs in some way. Out of these, 33 will provide advice to patients. 27 of these 33 tend to provide verbal advice only, and 2 would provide written and verbal advice. Only 1, a consultant, was aware of formal Royal College guidelines. During phase 1, 147 procedures were recorded. It was pretty even between laparoscopic and open repairs. Out of the 147 procedures, only 15 cases had documentation in the clinic letters, 12 in the operation notes, and 6 in discharge summaries. That's 10, 8, and 4% respectively, which unfortunately is not optimal. So what did we do next? We made a patient-friendly driving leaflet. We presented the project at our local departmental meeting. We educated the staff on the Royal College guidelines. To optimize compliance and not add extra work to staff members, we advised that it would suffice to document driving leaflet given. We distributed the leaflets to clinics and wards and included it in the e-consent and nurse-led discharge bundles. We also plan to educate junior members of the team during their induction upon rotation into the department. This is a picture of our leaflets. I'll give you a minute to look through it. So what happened following intervention? Phase 2 involved 29 cases with similar distribution between laparoscopic and open approaches. There was a marked improvement. Out of the 29 cases, driving advice was documented in 6 clinic letters, 13 operation notes, and 12 discharge summaries. That's 21, 45, and 41% respectively. Is this significant? The answer is mainly yes. We used Fisher's exact test in view of the low numbers, but we found that when it came to operation notes and discharge summaries, the improvement was statistically significant. To conclude, intervention with patient-centered leaflets and educational staff with guidelines is essential to provide patients with consistent evidence-based information. This information on driving following inguinal surgery should be both verbal and written for patient safety and to satisfy the GMC good medical practice. Thank you for your time.